Imagine you're just sitting on your couch watching TV. You know, it's a completely normal Tuesday.
Right. Just relaxing.
Exactly. You haven't exercised, you aren't stressed, you're not scared. But then, in the space of just a single heartbeat, your chest starts pounding at like 200 beats per minute.
Oh, wow. Yeah.
And you can feel it pulsing right up into your throat. It's like your heart's cruise control has just jammed at maximum speed and you have, absolutely no idea how to turn it off.
Yeah, for the person experiencing it, I mean, it literally feels like the engine is about to blow.
I can imagine.
It is sudden, it's terrifying, and it's this really stark reminder that the heart isn't just a physical pump.
Yeah.
It is a highly complex electrical grid.
And sometimes that grid glitches.
It definitely does.
So whether you are, say, a medical student prepping for the wards, a resident studying for your boards, or just someone who is insanely curious about how the human body gets its wires crossed, this deep dive is for you. Today, we are dissecting PSVT. That's paroxysmal supraventricular tachycardia. And we are synthesizing a massive amount of clinical data today, right?
Oh, yeah. Ton of it.
We've got insights from the JAMA network, some really deep dive case studies from the American Heart Association, and we are grounding all of it in the state of the science USMLE and MRCP clinical standards, drawing directly from the notes of Dr. Esafullah, KMU, MS Kohat.
Yeah, it is just a phenomenal stack of sources. I mean, we're really bridging that gap between textbook pathophysiology and, well, the high-stakes reality of the emergency room.
That is the mission. We're basically building the ultimate clinical roadmap for SVT today for you guys.
Right from the ground up.
Exactly. We're going to cover how to spot the symptoms, decipher the ECG, master the acute emergency management when, every single second counts, and even look at the long-term, high-tech invasive cures.
It's a lot of ground to cover.
It is. So we really should start with the P in PSVT because it kind of dictates how this entire condition behaves in the wild.
Right, paroxysmal. That word is just so key here.
What does it actually mean for the patient?
Well, it basically means the onset and the termination are totally abrupt. It hits like a light switch, not a dimmer.
Not a gradual buildup at all.
No, exactly.
Yeah.
And as you mentioned with that couch scenario earlier, patients often describe the palpitations localized, not just in the chest, but actually up in the neck or the throat.
Oh, really? In the neck?
Yeah, it's a very classic hallmark we see in the clinical data.
And along with that, the sources say they report sudden shortness of breath, lightheadedness, or just this really profound sense of anxiety.
Which is completely understandable.
Right. But I think a lot of people hear fast heart rate, and they just assume it's a normal stress response. Like if a bear jumps out at you, your heart rate spikes.
Sure.
That's sinus tachycardia. I like to think of sinus tachycardia as a car speeding up because the driver is intentionally stepping on the gas pedal, right?
That's a good analogy, yeah.
Like you're bleeding, you're in pain, you're dehydrated, your body is actively hitting the gas to compensate for something. But SVT is, it's a totally different mechanism.
Yeah, the underlying physics are entirely different. In SVT, the problem isn't some external threat telling the heart to speed up. It's an internal short circuit.
A glitch in the wiring.
Exactly. We refer to this clinically as a reentry circuit. And to really understand this, we have to look at the AV node.
The atrioventricular node.
Right. Normally, this acts as this single electrical bridge, or like a toll booth, between the top chambers of the heart, the atria, and the bottom chambers, the ventricles.
Okay, so the electricity is supposed to travel down in just one smooth, coordinated wave.
Exactly. But in many patients with PSVT, they have this microscopic anatomical quirk. Inside, or right next to that AV node, they actually have two distinct pathways for electricity to travel.
Two pathways instead of one.
Right. One pathway conducts signals very quickly, but it takes a long time to reset itself.
Oh.
And the other pathway conducts very slowly, but it resets almost instantly. And we call the central tissue right between them the central obstacle.
Okay, so you have a fast lane and a slow lane. So what actually triggers the racing heart then?
A premature beat. So an early electrical spark comes along and it tries to go down the fast pathway, but that pathway hasn't reset yet.
Because it takes longer to reset.
Exactly. It's blocked. So the signal, it has to take a detour down the slow pathway. But here's the trick. By the time it reaches the bottom of the slow pathway, that fast pathway has finally reset.
Oh, I see where this is going.
Yeah, the electricity actually turns around, travels backwards up the fast pathway, and loops right back into the slow pathway all over again.
Wow. So it just creates this continuous electrical roundabout.
Precisely. It creates a closed loop. It's spinning round and round at maybe 180 or 200 times a minute, firing off a heartbeat with every single rotation.
That is wild. It just completely hijacks the heart's normal pacemaker.
It really does. And when this loop happens right inside the AV node, we call it AVNRT. That's atrioventricular nodal reentrant tachycardia.
Right, the most common one.
Yeah. And if it uses an extra accessory pathway outside the node, it's called AVRT. Together, those two make up the vast majority of PSVT cases.
Which brings up a massive diagnostic hurdle, right? Because if this circuit turns on like a light switch and turns off like a light switch, a patient could easily have, say, a 20-minute episode at home.
Yeah.
And then they drive to the ER, and by the time we hook them up to a monitor, their heart rate is a perfectly normal 75 beats per minute.
Oh, it happens all the time. And this is exactly where diagnostic strategy comes in. Because diagnosing PSVT absolutely requires capturing the actual event on an ECG.
You have to catch it in the act.
Right. If they are actively having an episode right there in the clinic, you just get a short-term 12-lead ECG. Done. But if they are asymptomatic at the time of evaluation, you have to match your monitoring technology to the cadence of their symptoms.
So, like, if a patient tells you, hey, doc, this happens to me every single day right after lunch, a standard 24 or 48-hour Holter monitor is perfect.
Exactly. You just send them home with it and wait for it to happen.
But what if they say, well, it only happens randomly, maybe once a month? A 48-hour Holter is statistically useless for that.
Totally useless. For those patients, we have to step up to adhesive patch monitors. They can be worn continuously for up to 4 weeks.
Oh, wow.
4 weeks.
Yeah. Or we use event monitors that the patient actually activates themselves only when they feel the symptoms starting.
Okay, but what about the extreme cases? The ones who just, pass out completely out of nowhere once a year. You can't wear a patch for a year.
No, you can't. So for rare, highly dangerous presentations, like unexplained syncope, we utilize implantable loop recorders.
Right.
These are tiny devices. They're about the size of a paperclip, and they're just injected right under the skin of the chest.
That's incredible. Yeah, they have a battery life of several years, actually. They constantly monitor the rhythm. It kind of acts like a black box flight recorder for the heart.
That is fascinating. But let's bring this into the acute setting, because this is where things get really intense. Let's talk about the crossroads of care.
Right. The ER presentation.
Exactly. The patient is physically in front of you in the ER, and the monitor is just screaming at 200 beats per minute. Now, a core USMLE and MRCP clinical standard dictates that the very first question you ask yourself isn't, what drug do I push?
Yeah, definitely not.
The first question is, how much time do I have?
Which is such a critical mindset shift.
Yeah.
You have to treat the patient, not just the monitor. You have to immediately assess their clinical stability.
Right, the ABCDEs.
Exactly. You run through your ABCDEs, airway, breathing, and I should note here, you only apply oxygen if they are actually hypoxemic.
Oh, right, because routine oxygen for everyone is kind of an outdated practice.
Slightly outdated, yeah. Then C is circulation, meaning establish large bore IV access and get a blood pressure immediately. D is disability, assessing their mental status. Are they alert? And E is exposure, looking for obvious physical triggers like maybe a fever, hyperthyroidism, or signs of some sort of toxidrome.
And during that primary survey, you are actively hunting for the red flags of instability, right? Because this is the threshold that dictates the entire treatment algorithm.
The entire thing, yeah.
Yeah.
The criteria are very strict. We're looking for hypotension, clinical signs of shock, acute heart failure, pulmonary edema, ischemic chest pain, or an altered level of consciousness.
So if they are confused or their blood pressure is tanking.
Right. If any of those are present, the patient is officially unstable.
And if they are unstable, the guidelines mandate immediate synchronized DC cardioversion.
Immediate. Yeah.
You do not delay this to draw up medications, right?
No, absolutely not. The patient's brain and organs are not getting enough blood flow. You need electricity immediately.
Okay, let's break down the actual mechanics of that shock, because we hear the term synchronized cardioversion all the time. Why can't we just grab the defibrillator paddles, yell clear, and shock them the way they do in the movies? And what kind of energy are we actually delivering here?
Well, first off, we use a starting dose of 50 to 100 joules with a biphasic defibrillator.
Okay, 50 to 100 joules.
But the synchronization part, that is the difference between saving the patient and literally causing a lethal arrhythmia.
Wait, really? Lethal?
Yes. When you hit the sync button on the machine, the defibrillator reads the patient's ECG on the screen, and it places a tiny marker on every single R wave.
The R wave being the tall peak of the heartbeat, right? The ventricular contraction.
Exactly. So when you press the shock button, the machine doesn't just fire instantly. It will actually wait a fraction of a second to deliver the electricity exactly on that R wave.
But why does that specific millisecond matter so much?
Because the alternative is hitting the T wave. The T wave represents ventricular repolarization. That is the exact moment the heart cells are resetting their electrical gradients.
So it's vulnerable.
Highly vulnerable. If you deliver a large shock of electricity right on top of the T wave, you induce a phenomenon known as R on T.
And what does that do?
It instantly fragments the electrical activity and throws the patient directly into ventricular fibrillation.
Oh, wow. So you essentially take a patient who has a pulse, albeit a really fast one, and you accidentally turn them into a full cardiac arrest.
Exactly. You kill them. So the machine must synchronize with the QRS complex to safely reset the entire electrical grid all at once.
That makes total sense.
Yeah. And obviously, alongside this acute management, we also draw standard bloods, right? CBC, electrolytes paying special attention to potassium, magnesium, and calcium.
Right. Plus
a troponin to rule out ischemia, and a TSH for thyroid function. Oh, and an echocardiogram, just to ensure there's no underlying structural heart disease.
But let's look at the other side of the algorithm now. The stable patient.
Okay, much less stressful.
Right. Their blood pressure is, say, 120 over 80. They are totally alert, sitting up, and mostly just highly annoyed that their chest feels like a washing machine.
Yeah. Now we actually have the luxury of time. We start with non-pharmacological interventions.
Right. We aim to stimulate the vagus nerve. The vagus nerve supplies parasympathetic tone to the heart. It effectively acts like a brake pedal on the AV node.
So if we press that brake hard enough,
we can stall the reentry circuit and just break the tachycardia entirely.
And the sources specifically highlight the Revert technique here, which I know is heavily tested on clinical boards.
Oh, absolutely. It's huge.
Because we used to just tell patients to do a standard Valsalva maneuver, right? Basically just bear down like they're having a bowel movement.
Right.
But the Revert technique modifies this for a much, much higher efficacy.
It does.
You have the patient sit at a 45-degree angle, and they forcefully blow into a 10 milliliter syringe for 15 seconds. And it actually requires a surprising amount of force to move that plunger.
It really does.
And then immediately after that 15 seconds, you lay them flat on their back and raise their legs in the air to a 45-degree angle.
The physiology here is just brilliant.
Walk us through it. Okay, so blowing forcefully into the syringe increases intrathoracic pressure right in the chest.
Yeah.
Then, when you suddenly lay them flat and raise their legs, gravity causes this massive influx of venous blood to return to the right side of the heart from the legs.
Oh, I see.
Yeah, so this sudden stretch on the heart muscle, combined with the release of the intrathoracic pressure, massively amplifies that vagal reflex.
Wow.
It boosts the success rate of terminating the arrhythmia to like 40 or 45%.
Yeah.
It vastly outperforms the standard Valsalva.
It really highlights how interconnected the plumbing and the electrical systems are in the body.
It really does.
But okay, let's say the Rever technique fails. Now we reach for the crash cart medications. And the frontline drug here is adenosine.
Yes, the classic.
I always picture adenosine like dealing with a frozen Wi-Fi router. When the lights are just blinking chaotically and nothing works, you can't just press a button. You have to physically pull the power cord out of the wall, wait a beat, and plug it back in.
That's a great way to think about it.
Adenosine is basically the chemical equivalent of pulling the power cord on the AV node.
It forces a total hard reset. Adenosine briefly hyperpolarizes the AV node. It causes a transient complete heart block. It physically stops the reentry circuit from spinning.
And the dosing regimen for this is super critical.
It's extremely critical. It's a rapid IV push of 6 milligrams. And because it has a half-life of less than 10 seconds in the blood, it has to be pushed as fast as humanly possible.
10 seconds. Wow.
Yeah, so you push it fast, followed immediately by a rapid 20 milliliter saline flush, and then you actually elevate the patient's arm to let gravity help it reach the heart before it breaks down in the blood.
Right. And what if that first dose doesn't work?
If the 6 milligram dose fails after 1 to 2 minutes, you administer a 12 milligram dose. And you can repeat that once more for a maximum total dose of 30 milligrams.
I can't imagine this is a pleasant experience for the patient.
It is notoriously awful.
Yeah.
As a clinician, you must aggressively warn the patient before you push the drug. Because you are inducing brief asystole, the heart literally stops for a few seconds.
Wow. That's terrifying.
So patients experience severe flushing, chest tightness, shortness of breath, and a very visceral sense of impending doom.
Impending doom.
Literally. If you don't warn them, they will panic and they will think they are dying right there on the table.
And clinically, there is a major contraindication we have to watch out for with this drug. You never give adenosine to someone with severe asthma or active bronchospasm.
Never.
Because it can trigger a severe life-threatening asthma attack.
Yeah, exactly. So in those asthmatic patients, or if the maximum dose of adenosine just didn't work, we shift our strategy to longer-acting AV nodal blockers.
Okay, what are options there?
Assuming the patient is still hemodynamically stable, we use calcium channel blockers, specifically for Apamil at 5 to 10 milligrams, or diltiazem. Or, alternatively, IV beta blockers like metoprolol. These medications alter the calcium or sodium channels in the AV node, and they slow the conduction velocity just enough to make that reentry circuit physically unsustainable.
Makes sense. But, and this is a huge bet, this all assumes a very specific presentation on the monitor.
Yes, it does.
Everything we've discussed so far is predicated on the ECG showing a nice, narrow, regular QRS complex, right?
Right.
Because that narrow spike tells us the electricity, even though it's spinning fast in the top of the heart, is still traveling down the normal standard highways of the ventricles.
Exactly.
But what happens if we look at the monitor and the QRS complex is wide, bizarre, and irregular?
Then you are standing in the middle of a diagnostic minefield.
A minefield.
Truly. The AHA case studies dedicate significant attention to this exact scenario, specifically focusing on Wolff-Parkinson-White syndrome, or WPW.
WPW. So this fundamentally changes the anatomy, doesn't it?
It completely changes it.
Because these patients are born with an extra abnormal band of electrical tissue connecting the atria and the ventricles. It's this accessory pathway that completely bypasses the AV node.
Right. And we can often spot this on a resting ECG when their heart rate is totally normal.
How does it look?
It manifests as a delta wave. Because some electricity kind of leaks down this extra pathway and activates the ventricle early, the QRS complex has this slurred early upstroke.
And the sources mention that this delta wave can sometimes look like a Q wave, right? Which creates a pseudo-infarct pattern that actually tricks doctors into thinking the patient had a heart attack.
Yeah, it's a very common misdiagnosis. But here is the fatal trap with WPW.
Okay.
Let's say our WPW patient is in the ER. The monitor shows a wide, irregular tachycardia. Their heart is racing.
Right.
If the goal is to slow the heart down, why can't I just give them adenosine or verapamil like everyone else?
Because doing so will likely cause sudden cardiac death.
Exactly. But to understand why, you have to look at the rhythm. A wide, irregular rhythm in a WPW patient usually means they're in pre-excited atrial fibrillation.
Okay.
The top chambers of their heart are fibrillating, generating chaotic electrical impulses at like 300 to 400 beats per minute. Now, normally the AV node acts like a toll booth, right?
Right.
It protects the ventricles by only allowing a fraction of those 400 impulses to pass through.
So the toll booth creates a necessary bottleneck to protect the rest of the heart.
Exactly.
Yeah.
But our WPW patient has that accessory pathway.
Ah.
So think of it as a wide open, unregulated dirt road running right next to the toll booth.
Oh, no.
If you give adenosine or verapamil, you completely block the AV node. You shut down the toll booth.
Which means all 400 of those chaotic electrical impulses have absolutely nowhere to go but down the dirt road.
You got it. All of that chaotic electrical traffic is forced down the accessory pathway directly into the ventricles.
Yeah.
So the ventricles suddenly try to contract 300 times a minute. The muscle simply cannot sustain that mechanical rate, and the rhythm instantly degenerates into ventricular fibrillation.
And the patient loses their pulse.
Instantly. AV nodal blockers are absolutely universally contraindicated in pre-excited AFib.
That is a terrifying physiological trap. Just terrifying. So if we can't block the node, how do we actually treat them?
Well, if the patient is unstable, you immediately perform synchronized cardioversion, shock them.
Right.
But if they are stable, you use medications that target the accessory pathway itself, not the AV node. The AHA guidelines strongly recommend IV procainamide or ibutylide.
Because they target the dirt road.
Exactly. These drugs slow conduction in that unregulated dirt road, bringing the rhythm under control safely.
Okay, so let's look beyond the emergency room now. Once the patient actually survives the acute episode and they're discharged, how do we prevent this from ruining their quality of life long term?
Well, we usually start with conservative management. Lifestyle modifications are really crucial, avoiding dehydration, managing stress, and definitely cutting back on heavy stimulants like excessive caffeine or, energy drinks.
Makes sense.
From a pharmacological standpoint, some patients do really well with the pill-in-the-pocket approach.
Oh, where they take a beta blocker only when they actually feel an episode coming on.
Right. While others require daily maintenance therapy with beta blockers or calcium channel blockers just to suppress the ectopic beats.
But the clinical literature notes a significant limitation there because SVT frequently affects young, highly active people, right?
It does.
So if you prescribe a daily beta blocker to a 22-year-old, you are essentially artificially capping their maximum heart rate.
Yeah, you are.
They are going to complain of chronic fatigue. They won't be able to run, play sports, or work out the way they want to. It's a massive quality of life hit.
It's a huge issue, which is exactly why the gold standard definitive cure is catheter ablation.
Right, ablation.
It is a true marvel of modern electrophysiology. I mean, instead of managing the symptom, we just eliminate the anatomical cause.
This is the EP study.
Right. It's typically a same-day procedure, takes about an hour and a half. An electrophysiologist threads several thin catheters up through the femoral veins in the groin and straight into the heart.
Okay.
These catheters have tiny electrodes that literally map the heart's electrical grid in real time. And the physician will actually pace the heart, intentionally trying to trigger the SVT right there in the lab.
They trigger it on purpose.
Yes, because once they trigger it, they watch the electrical signals to pinpoint the exact microscopic location of the slow pathway in AV-NRT or the accessory pathway in AVRT.
Once they find that specific millimeter of tissue, what then?
They deliver thermal radiofrequency energy, or sometimes they use cryotherapy, to basically burn or freeze that exact spot.
Just destroy it.
Exactly. This creates permanent localized fibrosis, just a tiny scar. And since scar tissue cannot conduct electricity, the re-entry circuit is physically destroyed.
That's amazing.
It really is.
Yeah.
For AV-NRT and AVRT, catheter ablation boasts a definitive cure rate of over 95%.
That's an incredible success rate, truly. But, the AHA case studies also dive into some special populations where the baseline rules kind of have to bend a bit.
They definitely do.
Let's look at hypertrophic cardiomyopathy, or HCM. They detailed a case of a 17-year-old girl with HCM who developed SVT. Why does this specific structural disease make SVT so uniquely dangerous for her?
It really comes down to the physical shape of her heart and this concept of diastolic filling time.
Okay.
In HCM, the walls of the ventricles are abnormally thick. And because they're thick, they are stiff. They don't relax easily.
Right.
Therefore, her heart requires a much longer time between beats to physically fill up with blood before it can pump it out.
Oh, I see. So if her heart suddenly gets locked into SVT and starts beating at like 180 beats a minute.
She completely loses her filling time. The heart is squeezing so fast that those stiff ventricles just remain mostly empty. Her cardiac output drops to near zero almost instantly. A fast heart rate causes rapid, severe hemodynamic collapse in HCM patients.
That's terrifying.
Because the structural margin of error is so small, electrophysiologists have a much, much lower threshold to perform an ablation on an HCM patient. You really have to remove that arrhythmia from the equation entirely.
That makes total sense. Now, everything you're saying makes sense for a 30-year-old adult or even a 17-year-old, but SVT is the most common arrhythmia in children?
It is.
I'm picturing a toddler coming into the ER with this. We can't possibly just thread a catheter in and burn a tiny infant's heart, right?
How does the physical size of the patient change the math here?
The physical size changes everything. Ablations in infants carry a significantly higher risk profile.
Because everything is just so small.
Exactly. Their hearts are so small and the walls are so thin that the physical distance between the abnormal pathway and the normal AV node might be just a millimeter or two.
Oh. So the risk of accidentally burning the normal AV node and requiring the child to have a permanent pacemaker for the rest of their life is much, much higher.
That's a huge risk.
It is. Therefore, pediatric cardiologists will aggressively manage the SVT with medications until the child hits a critical safety weight.
And what's that target weight?
Generally, the threshold is 15 kilograms. That puts the child roughly in the toddler range, around 3 or 4 years old. Once the heart is that size, elective ablations become statistically much safer.
That is so interesting.
Yeah.
Let's consider two other unique groups really quickly. Professional athletes and pregnant patients. What if I have an elite athlete who absolutely refuses daily medications because it just ruins their performance?
Well, high adrenergic tone, meaning high adrenaline, is a powerful trigger for SVT. And athletes push their bodies into that trigger zone every single day.
Right.
Because beta blockers destroy their competitive edge, ablation is heavily favored as early as possible so they can just continue their careers unimpeded.
And what about for pregnancy? Because you have the increased blood volume stretching the heart and the physiological stress triggering more episodes. But you are essentially treating two patients at once.
Right. Pregnancy requires highly specialized maternal-fetal electrophysiology coordination. You obviously want to avoid ablating during pregnancy, if at all possible, due to the required fluoroscopy.
Right, the radiation exposure to the fetus.
Exactly. So you have to carefully select medications that are safe for fetal development while still controlling the maternal heart rate, and you reserve invasive procedures only for truly refractory, life-threatening cases.
Wow. We have covered a massive amount of clinical ground today. To lock this in, we're going to recap with a really high-yield mnemonic that synthesizes the USMLE and MRCP standards we've discussed.
Perfect.
It's SVT pair, S stability first. Assess those red flags. If they are unstable, you shuck them.
Right.
V vagal maneuvers, remember the revert technique with the syringe and the leg raise? T treat with adenosine, the rapid push, the hard reset of the node.
Unless they have asthma.
Exactly. C calcium channel or beta blockers if adenosine fails or is contraindicated. A ablation, the EP study that provides a long-term, definitive, greater than 95% cure.
The gold standard.
Rule out WPW, look for that delta wave, and never ever give AV nodal blockers in wide, complex, irregular tachycardias. And finally, EEP study when indicated to map and destroy those hidden pathways.
It's an essential checklist for navigating the real-world realities of this condition. But, looking toward the next decade of medicine, the JAMA literature raises a profoundly important challenge regarding how these patients were initially diagnosed.
What's the challenge?
Well, patients are walking into clinics every day now, handing us Apple Watch ECGs that flag an SVT.
Oh, yeah. The technology is everywhere now.
It is, but the algorithms diagnosing these rhythms inside consumer wearables are essentially a black box.
What do you mean by that?
They're proprietary codes owned by tech companies, not validated clinical tools owned by doctors. This raises a really critical question for you, the listener, to ponder. How will the medical community validate and trust AI-driven consumer-grade algorithms when the stakes are this high?
Right.
If a watch algorithm misses a subtle delta wave and a clinician blindly trusts that output and pushes adenosine, the result could be fatal.
Wow. We crave the certainty of an X-ray showing a broken bone, right? We just want the watch to hand us the exact answer.
But it's not that simple.
No, the electrical system of the heart is complex and it's unforgiving. When the wiring glitches, you really need a clinician who understands the mechanics of the machine, not just the alert on the screen.
Treat the patient, not the monitor.
Exactly. Treat the patient, not the monitor. That's all the time we have for today. Stay curious, stay informed,